August version of our Impact Research Seminar series. To begin today's webinar, I would like to acknowledge the tradition and custodianship of the lands of the First Nations people that we're working and enjoying a very sunny afternoon in Sydney from. Today I'm actually at home, which is on the land of the Darawal people, and I pay my respects to elders past, present and emerging. It's with great pleasure that I introduce one of our colleagues and an academic whiz who never fails to produce some sort of pink attire. So we were destined to be colleagues in whatever life possible. And that is Dr. Sally Ayesa. And Sally's this afternoon kindly accepted the invitation to give a presentation on how radiologists learn. And of course, this is vitally important to not only the Impact project, but many of the research projects that we engage with, where we consider the search and the perception and the learning and recognition and that memory bank that goes behind how radiologists interpret images. So to give you Sally's official bio, Sally is a clinical radiologist and nuclear medicine physician working across Gosford, Wyong and Royal North Shore hospitals here in Sydney. She's a lecturer within the Sydney Medical School and unit coordinator within the Master of Medicine and Surgery programs. Dr. Ayesa is a member of the Radiopedia editorial board and sits on the Curriculum Assessment Committee and the Diversion Inclusion Task Force for the Royal Australian New Zealand College of Radiologists. She's also the co-director of radiology training on the Central Coast, where she's the clinical lead for ultrasound imaging. Her research interests include thoracic oncology, diversity and inclusion, and medical education, which is also the topic of her PhD. Sally is the convener of the RANZCAR Centralised Learning Program and the upcoming Radiopedia 2024 conference. And it is great with pleasure that I invite Sally to share her screen and commence her talk.
Thanks so much, Sarah, and thank you so much to Impact for having me along today. I'll just quickly share the screen so you can see the presentation. Okay, there we go. So very, very big thank you. And I have to say that this was a really challenging talk to write. And I'm so kind of very, very grateful to Impact for asking me to really sit and muse about this particular topic. Because how radiologists learn is, it's a lifelong skill building exercise, and it's so complex in its many facets. So to allow me time to unpick it and really kind of think about that has been a great privilege. So I'm joining you today from Gosford Hospital, and I'm on the land of the Darkingham people. And I'd also like to pay my respects to people in country. As you heard in that excellent introduction, thank you very much. I am a radiologist and I'm a nuclear medicine physician. So I've got 2 fellowships, and I spend a lot of time, particularly with my research and teaching my trainees, mentoring junior doctors through radiology, and also working with other specialists, thinking about how we learn best. And in my role as a director of training and also a clinical staff specialist at a public hospital, part of what at the core of what we do is teaching more junior radiologists how to grow into safe and effective clinicians and practitioners, and ultimately benefit our patient care. So I guess kind of starting at the very, very beginning, I'm just going to minimize. So we're just kind of starting to think about what is a clinical radiologist. And this is me. This was on Christmas Eve, just after Wyong Hospital opened. And basically, a clinical radiologist, we're medical doctors. We've been through a medical degree, whether that be postgraduate or undergraduate, and we specialise in using medical imaging techniques in the diagnosis, treatment, and ongoing management of a range of clinical conditions. And that kind of comes into diagnostic radiology, which will be things like CT scans, ultrasound, ultrasound, MRI, X-rays, lots of different imaging modalities where we're looking at the diagnosis, but it also encompasses procedural radiology, where we use different imaging techniques to guide interventions. And that might be using ultrasound and fluoroscopy to place a PICC line, or using CT to guide biopsy of a lesion. And there's lots of different facets within these, within radiology, and different subspecialties. And we're a very diverse group of clinicians. Also, just pausing in here as well to talk a little bit about nuclear medicine as well. So in Australia, nuclear medicine is a different fellowship pathway, but you can do it after you finish radiology as an additional 2 years, or you can also subspecialise in nuclear medicine through a physician pathway as well. So there's different, so they are senior doctors. It is a full accreditation program and a different skill set, but I really like doing both. I think they're very complementary. And for someone like me who has an interest in cancer imaging, I think that the two really work well together, and I really like what I do. So thinking about how radiologists learn, and as I said at the beginning, this was a really interesting topic to me, because I really, sitting and reflecting, it was like, how did I get here? and I must admit, I cheated. I asked the AI chat, how do we learn? And I liked what it said. So it said, it's all about a combination of formal education, practical training, and continuous learning. And that's at the crux of what we do, is we take our baseline medical education that we receive through our university degrees, and then we build medical imaging into that. And it's not just a matter of looking at the image in front of us and going, there's your problem. It's more about taking what we see and bringing it into the patient journey, comparing it, thinking through the problem, to end up with at least an impression or a diagnosis to assist with the clinical care of the patient. We work very closely with other clinicians as well to assist in that care journey. There is a formalised training program that we go through, and we'll take you through that in just a moment. But at its kind of heart, we're looking at really an apprenticeship model, and it's also just reporting or interpreting or learning through many, many, many scans over many, many years to build a bank of expertise. So in terms of kind of a formal starting point, we're thinking about a combination of formal education, practical training, and continuous learning throughout one's career. And we achieve that professional development through workshops and courses and reading scientific literature, in addition to our on-the-job learning, which our training program is accredited by the Royal Australian and New Zealand College of Radiologists in Australia, which is a series which I'll take you through in a few slides' time. But that's a formal training accreditation. And so to practice as a specialist radiologist across Australia and New Zealand, you need accreditation from that body. So in things that are important in my ongoing learning now is essentially staying up to date with those advancements, particularly as technology improves, like looking at PET scans, for example, positron emission tomography, where we were 20 years ago to where we are now, especially with University of Sydney having the new Quadra scanner at North Shore, which we're very, very proud to have, the total body PET, things are so different. And with that, improving technology requires a need for staying up to date with these advancements, and also not only the technology, but also our knowledge of medical conditions, and how our knowledge of patient healthcare changes over time. And that technology will come into education, and even just sitting here today doing a webinar for how we talk about radiology has really revolutionized how we teach and how the global radiology community connects. You would have seen through my bio that I work through Radiopedia, and having online conferences and connecting with colleagues in the UK and in the US, and being able to teach and share my knowledge with registrars all over the world is, something that's really kind of revolutionized how we do things. We think about technology with image interpretation, and also increasingly we're considering the role of AI and machine learning. At the heart of that lifelong learning journey into radiology is we're always got to keep at the heart of what we do is that highest quality of patient care. How can we do the best for our patients? And then continually update and refresh that knowledge, and also adapt to the new technology as we saw. So this is my little kind of flow chart of how a radiologist comes to be. So we all start with a medical degree, and that might be an MD or an MBBS. I would train through UNSW, and then when you successfully complete your medical training, you go into internship and residency, which is 2 years of postgraduate, like general generalist practice. So that will be in a hospital where you will rotate through different parts of medicine to get that broad general clinical experience and to kind of teach a lot of those problem-solving skills and how to function in a complex clinical environment. For example, for my internship, I did emergency medicine for 12 weeks, and then I went and did some renal medicine. I did vascular surgery, I did cardiology. So I got all of those different on-the-ward experiences, which really kind of started to cement all of the basic knowledge and kind of those early practical skills I got in my medical degree. Depending on your selection and your own journey, you may do a senior resident year, you might do a junior registrar year, which is before you're accepted onto an accredited training program, which is that formal teaching program to become a specialist. And some of my colleagues have even had, different journeys as well. They might have started in surgery, they might have done physician training, they might have, gone and done orthopedics and then decided to come to radiology training. But here is where we do that real formalized learning to find ourselves qualified as a radiologist to engage in independent practice. It's optional to do a fellowship post-training, but often very desirable. That's where a lot of our subspecialty interests come in. So I, for example, did nuclear medicine. I did an additional 2 years. Colleagues of mine are doing MRI fellowships, for example, to hone their skills. They might go to Canada and do a chest radiology fellowship. So you get that time to really hone your interests and upskill in a particular area, and then eventually qualifying as a radiologist, which is where I am at the moment. So thinking about the learning journey though, so the medical school is where we're laying down that baseline knowledge, and that comes in the terms of basic sciences, including pathology and anatomy, and also that theoretical clinical knowledge. For example, the ins and outs of Crohn's disease, or the theory behind lung cancer, the different histopathological subtypes, how diseases behave, what happens to the patient, bringing all of those facets of that baseline knowledge together. And then also in medical school, you start to develop clinical skills, and that comes into earliest patient assessment, how to examine patients, take a history, how to talk to them, how to get the information you need to be able to help them. And that's when you start to develop these problem solving and communication skills. At this stage in medical school, and it's certainly something that we're working on, particularly at Sydney University, as well as universities all around Australia and the world, is how we can incorporate early medical imaging knowledge into medical programs to start these even before they're doctors, aspiring and developing doctors. How can we instill medical imaging knowledge there so that when they get into the hospital environment, they're able to better assess their patients? But my philosophy with medical students is we want to be thinking about what tests should be used when. So not just, if you've got a patient who has come in with a headache and you're worried about them, what type of imaging modality would you pick? And that is not going to be the same for every single patient. You can think about the patient age. If they're 80 and they've got a headache, it'll be different to if they are 4 and they've got a headache. So you can decide whether CT might be the best or MRI might be the best, and how you would design that study to best answer your question. So how can we help the patient? And we also like to throw in some basic image interpretation skills at this point as well. For junior doctors, these are recently graduated doctors. They're now on the ward. We're thinking about practical experiences with patients, like how does that knowledge translate into the real world and take that theory into practice? How do we fit into the patient journey? And then developing those professionalism skills or intrinsic roles like teamwork, communication, cultural competency. And then further, if we can get the opportunity, which we try to do through sessions through the year, is developing that imaging knowledge, both in a didactic sense through lectures, but also and tutorials, but also how we can have on the ward and ad hoc teaching, or through multidisciplinary team meetings where we bring different doctors of different specialties all together into a room with a radiologist talking about imaging, talking about the diagnostic imaging, a nuclear medicine physician perhaps presenting a PET scan, a pathologist looking at biopsy results or tissue samples to employ that complex and collaborative problem solving to help our patients. and also keep working towards those imaging interpretation skills so that a resident who has just recently graduated, a year out from graduating, in the middle of the night, if they get a patient with a common or life-threatening scenario in the middle of the night, like a bleed on the brain, can they recognize it? Can they escalate it? And moving forward. And then we start to think about moving on to radiology training. So we're taking into account patient assessment, the role of imaging in scenarios, multidisciplinary care. So we're really starting to hone down to imaging specific skills. And they may grow these skills through radiology specific rotations or observerships where they go and visit a radiology department and shadow a radiologist, or even junior training roles. Sorry. The radiology training program is a 5-year accredited training program, and this has got a formal handbook with different learning outcomes that they will work through. Sorry about that. And so this takes into account summative exams, which is based into 2 parts through our phase training. So we get our radiology registrars to start with anatomy and physics as building blocks, because you really need that basic science and an understanding of patient anatomy to be able to interpret what we're seeing later on. So we get that nice and early, and then as the registrars progress through training, gaining more and more experience, then they will go towards their final exams, which brings into account radio diagnosis, which is what kind of our word for saying using the radiology to reach a patient diagnosis and to help and assessment, and then pathology, which is the capstone fellowship exams. All throughout that, though, there's also semi-formative assessments, so work-based assessments. How are you performing in your day-to-day reporting? How are you performing procedural skills? How are you interacting with staff members? And also throwing in research projects, critically appraised tasks where it's almost like a journal club where they pull in a patient scenario and then pull it all together, as well as e-learning modules, and also kind of additional assessments in that way. And the big thing that I put down the bottom is something called experiential training requirements. And that is a really, really big word for essentially how many scans have you reported? How many x-rays have you done? How many CTs have you done? How many MRIs have you done during your training? Because one of the pillars of what we do and we understand is that the more that you report, the better you're going to be. The greater the breadth of patient exposure, the different ways that different diseases can be seen on imaging is going to allow you to build that knowledge base. And the more you see, the better you'll be and the safer you'll be for your patients. So that's a really, really important one. So as I've kind of alluded to, radiology training in Australia and New Zealand, while we do have a formal curriculum, it really is an apprenticeship model of learning, looking at how we report and having those reports checked by a consultant who's now such as myself to see where you're doing well, and it's not even just about have you found the diagnosis or found the abnormality or you haven't. That continuous feedback also takes into account communication. Are you able to take what you see on the screen and clearly communicate it to the doctor who is looking after the patient? Are you able to problem solve and pull in A, B, and C findings on the imaging to give a clear interpretation? So it might even be, even today, I had a patient who was referred for an ultrasound of a mass, and we thought it related to the ovary. But when we got into the room and I saw the patient, we were scanning and even just checking before, we realized that there were additional problems and lymph nodes that were tracking down the leg. And being able to look at that pattern of those lymph nodes, we asked the question of the patient, have you ever had a skin cancer on her lower leg? And she said, oh, yes, here it is. And so being able to take all that information in and problem solve it, we were able to flip around our diagnosis from ovarian to thinking about metastatic skin cancer instead, just because of the patterns and just because of assessing the patients. We also think about formal and informal education sessions here on the Central Coast. Every single lunchtime for an hour, our trainees get an hour of dedicated teaching, and that might be a case readout where they're presented a case and then they tell me all about it, tell me the observations, tell me what they think the diagnosis is. And that also comes into practice oral exams. Or we may sit down for an hour and I might tell them all about PET scanning and nuclear medicine as a didactic tutorial or lecture. And then they will supplement that with courses and workshops. So that's really kind of the basics of the theory. And now we're going to do some more fun stuff about how we actually practically interpret imaging. And if you have any questions, just pop them into the chat. I can hopefully monitor it as we go. So, learning to interpret imaging. This is the book on chest x-rays that I recommend to all of my registrars when they start radiology training, because it was recommended to me. And this is the 4th edition of a kind of a key mark, my goodness, I can't think of the right word, but a textbook on the principles of chest radiology and how to interpret chest x-rays. And it's really quite corny. It has, like, you know, if you can, you know, with some little jokes to kind of help, you know, help you remember the content and engage with it. But the most important thing that I found from this textbook was the search pattern. And I am a firm believer that, you know, high-end radiology skills, it's all about honing our imaging assessment skills rather than just knowing what a pathology looks like and trying to spot diagnose it, or where's Wally it, as my PhD supervisor says. It's not about where's Wally. It's about having a systematic approach to looking at an investigation to maximize the chance you have of finding, of identifying and pulling together and diagnosing the patient correctly. So, you know, you can say, we start with a little bit silly. If you cannot tell a patient's left from right, you will look like a turkey, and there's a little turkey. But then we go on to the next page, which is this is where the meat of it is, thinking about how does my eye move across the chest x-ray so I can be confident that I have looked at every single inch of this patient's investigation and maximize my chance of looking for pathology. So this is how I interpret it, and this is now actually slides from when I teach medical students, residents, registrars, anybody. This is my animation, and which I've adapted from this book, which is we start by looking across the abdomen, up the side, across the top and down, so that you've looked at the periphery. And I like to start with the periphery because I know myself that it could be an area that I might miss. So, and then I will suggest that we look down the mediastinum, thinking about the contours and looking at each hilum to make sure that they are the right shape, they're in the right location, that there's no abnormal masses hiding there. Then we go to the hero of the chest x-ray, which is the lungs, and we go from top to bottom, comparing each zone as we go down. And we do that both sides, and then compare side to side. So we've looked at the lungs twice to maximize our chance of detecting pathology. Then after that, we check our costophrenic margins, which are these little triangles down the bottom, and the lung apices. And then when I've done all of that, I can be confident that my eye has looked at the entirety of the scan. So if there is an abnormality there to detect, I feel like I'm maximizing my chance of doing that. That said, it's always good to have to link back what you see to the clinical question. And that is something you should do for every single scan. You shouldn't just be looking at an x-ray just going, can I spot the problem? You've got to think about and remind yourself that the x-ray that you are seeing is a person. This is a person who has come into the hospital and had this x-ray for a specific reason. So I'll think, what have they come in with? Is it cough or shortness of breath? Or have they had a fall and we're worried about a fracture? And then you go back and you target your search based on what the clinical question is. So is there somewhere where I need to look again? And this patient came in with fever and cough with a travel history, and this patient had tuberculosis at the left lung apex. And it's a little bit subtle. It can be difficult to see. But if I knew that the patient was concerned, that there was a concern for tuberculosis or some kind of atypical infection, as we call it, not behaving quite as, you know, just a rip-roaring pneumonia, then I will go back and have a look to maximize my chance of finding that abnormality. So the next thing is actually more related to cross-sectional imaging, which is going to be our CTs and MRI scans. So stacks of pictures that we work our way through, representing the body in a three-dimensional way. And you can ask yourself if you are a scanner or a driller, which sounds quite terrifying, but it's actually just the method of how you look at the scan. So scanning is when you go slice by slice and you cast your eye over the entire scan, the entire slice before you move on to the next one. And this can be a little bit of a slower, but it's a little bit more of a thorough technique. But essentially, it's the same principle that you want to look at everything before you move on. But I am actually a driller. And so this was actually, I took this from a video I made for some of our MD students about what drilling is, which is where you train the eye on a small region of the image. So you can see where my cursor is, and I do the brain in quadrants. This is an MRI, and I will fix my eye where the little cursor is, and I will go down, looking through that area, and then go up and down. So you're looking at quadrants, keeping your eye fixated, and then you repeat that for each region. You repeat it on different stacks of images if you have that. So this is on an MRI brain, I would do this for every single one. If I was doing a CT, exactly the same. So you focus on a region and scroll up and down to try and maximize that region of pathology, that detection of pathology. But I'm making sure that my eye is going to every single part of the scan. And even though I will do this up and down for the meat of the brain, or the parenchyma, as we call it, I will still go back and have a look at some review areas with this technique, including the orbits, so that where the eyes and the globes of the eyes and the base of the brain, to make sure I'm not missing anything. And just a little bit of research to justify how I do things. But, this is with these visual search patterns, apparently driller performance was superior to scanners, including detecting lung nodules. And I'm a chest radiologist, so that probably, suits me. And also decreasing errors. So there's different ways of doing it, provided you're comprehensive. But that's how my eye goes when I'm looking through cross-sectional imaging. I probably would be amiss if we were talking about imaging interpretation without bringing up the gorillas on the CT scans. It was quite a famous study, and this came from the Washington Post 10 years ago now, that most radiologists don't notice a gorilla in a CT, which seems very sensational. But when you start to think about it, it brings into a really interesting discussion of an exploration of perception error. The radiologists were asked to look through 5 CTs, and they were counting lung nodules. So they were looking for bright white dots. And then on the final scan, there was a hidden gorilla just here, just hanging out on one slice and one slice only. And they were asked to count the lung nodules, and then they were asked if they saw the gorilla. And only 4 of the 24 radiologists actually picked that there was a gorilla hiding in one of the slices. So does that make us bad radiologists? Does that mean that we're going to miss pathology? Well, not necessarily. Why did we miss the gorilla? It's because we'll often be focusing on one thing. So if you're focusing on looking for things that could be in the lungs, like nodules, masses, fluid where there shouldn't be fluid, then you're not going to be looking for a gorilla. And also, you probably haven't seen a gorilla before, so your brain isn't set up to be able to recognize it. It was kind of classified as inattentional blindness, and you're looking for a white lung nodule, not a small black gorilla. So your brain is less likely to detect it. And interestingly, when they tracked the eye movements on this study, most radiologists looked right at the gorilla, but they just didn't see it because you weren't expecting to see it there. Just to kind of make you feel a little bit more confident in my specialty, and also just for my own pride, there were some native observers who did the study as well, just to compare. And unsurprisingly, radiologists did much, much better in detecting the lung nodules. And although only 4 radiologists found the gorilla, no naive observers found the gorilla. So it's not just a radiologist's problem. But yeah, a really interesting thing about inattentional blindness, which then brings me on to another concept that we find in radiology, which is called satisfaction of search, which is a really common diagnostic error, in that if you find the pathology, your brain can stop looking for more. And it's something that I did notice that I did a bit more when I was more junior, and I try and be more conscious of it now that I am more senior, but I'm not perfect. It does happen occasionally. That when the image reader ceases their search, so they find the abnormality, they can miss something different. And that can prematurely end, and it can be completely unconscious that your brain will tune out or lose engagement with the case. And so you are going through the motions of reading the scan, but you might not actually detect the finding. And to do that, I just kind of captured something from Radiopedia last night, and this was a big liver mass, and they were concerned that it could be a liver cancer. And so this was detected, and then I believe the initial scanner kind of went through, or initial reader went through and checked certain areas, but this abnormality down inferior to the left kidney, which we'll just see coming up here in a sec, where the cursor is there, this other abnormality can hide. You might not detect it. So now all of a sudden, rather than thinking that you've got a liver cancer, which is usually solitary, just in the liver, you've now got a second mass, which changes the way you interpret the study. And this pattern of multiple masses in this particular pattern turned out to be lymphoma, completely different diagnosis. But if you only focus on the liver lesion, you might miss this additional finding, which would change how you interpret the overall case. So moving on to assessment of a particular lesion, and this comes into our radio diagnosis skills. And I've picked a lung cancer because I do a lot of lung cancer, and it's what I teach my registrars most frequently. And here we have, this is a not particularly subtle mass in the left upper lobe of the lung. So this was cancer. I know it was cancer, but we're going to use it as an example for how we would assess a particular lesion and how I come to my decision about what the diagnosis might be and what to do. So the first thing I think of is why are they having the scan and in what context they are having the scan. If this is a first presentation, I'm going to look at this and read this very differently to somebody who is known already to have a lung cancer. Because if this is a new finding, this is a potentially very life-changing diagnosis that I'm about to make on my report. So what symptoms are they experiencing? Have they got cough? Are they coughing up blood? And therefore, we're going to consider the impact of what I say in that report on what the outcome may be. And when I think about something like this, a good first question I like to ask myself is, do I think this is aggressive or non-aggressive? And this kind of comes into how worried should I be and how worried should the clinician be? And I break this down as, could this be cancer? And this, taking even a step further, I'll tell my registrars, they'll be like, there is often a most likely diagnosis and a can't miss diagnosis. And asking yourself, could this be cancer, is really important because it allows you to think through. Some of this comes from Gestalt and that gut feeling which develops with increasing experience, but we also think about how imaging can help me make this decision, and then always linking back to the clinical history, which is the most important piece of information I have. Now, this is a busy slide, and I certainly, this is just something I actually stole from a lung cancer lecture I do, thinking about how I use evidence to help guide my search patterns and how I make decisions. And this is the overall staging for lung cancer tumour. So it's how we assess the primary tumour, and this information will help our oncology, so cancer doctors, medical and radiation oncology, and our surgeons make decisions on how to treat the patient. All of these things are important, and so that's why I take it really seriously to put these in my report and think about these when I'm looking at lesions. Firstly, how big is it? Secondly, what it is doing to its local environment. Is it surrounded by lung? Is it invading into structure? And then if it is, what is it involving? Because depending on what structure is involved or invaded, that is going to change the management of the patient. So it's a really important thing for me to think through when I'm assessing the CT, because it will help my clinician colleagues to make the hard decisions. And then we think about what it's doing to the surrounding environment as well. So is it causing the lung to collapse? Is it obstructing the lung? Or is it spread to different parts? So let's think about that. So location, where is it? Really important. How big is it? And its density, which is thinking about how bright or dark it is on the CT scan, because that can give me a clue to whether I'm looking at fluid or soft tissue. And then the borders or the margins, which can give me clues to whether it's aggressive or not. And this, we call this spiculated, but this kind of jagged spiky border tells us that it's more of an aggressive process. Then I think about what it's doing to the surrounding tissues. Is it invading or extending? Is it destroying something, like eating away the bone? And is there mass effect, which is our way of describing whether or not one lesion is pushing on another and causing things to move around that shouldn't move. So that's where our anatomy comes in really important. And then thinking about complications. So my shorthand is, causes, complications, associated findings. And this is really about whether or not what I see is causing or has the potential to cause further harm. And that can be causing things to leak, things to bleed, things to become infected secondary to the mass. And then moving further than that, so now I've assessed what we see, and let's have a think. What could have caused this? Is there a disease that the patient had which can give rise to this imaging appearance? Have they had an exposure? Like, for example, have they smoked for the last 40 years, a pack a day, and are they more likely to have lung cancer? And then think about other abnormalities elsewhere in the scan which I need to consider. And this is also another leading straight into associated findings, which is what else could I assess for in this condition? And that it may be staging a cancer to see if it has spread to other organs, and if in a chronic condition, if other organs or tissues might be involved. So this is just, this is a case of a very angry looking lung cancer, different to what we saw before. But when I look at this, some things I will think about is vascular invasion, because this tumour is growing into the blood vessels. I'll think about the fluid that is surrounding the heart as it's caused from it growing into it. I'll think about what it's doing to the bronchus, so it's narrowing it, so those airways are being narrowed, and thinking about invading into the tissues surrounding the heart and those big vessels in the chest. So now moving on to problem solving and clinical recommendations. And so when we think about problem solving, it's not just necessarily about, as we saw before, looking at the scan and going, that's this. There's so much more to what we do as radiologists by pulling in the different facets of the clinical process. So the first one, yes, it's the study you're reading. What is the imaging in front of you? And as a way to test myself, actually, I'll often look at the imaging first without looking at the clinical history, see what I think just by looking at it, and then I'll go on and think about why the patient is here. I often find that sometimes allows me to detect things that I might not find by jumping in first and going, we're worried about liver disease, so I'll just look at the liver. It allows me to look at everything, get a bit of an idea, and then go back and hone in, and then potentially find things that I might not have seen otherwise, and also change my perspective. And then we also think about previous imaging, other tests like blood tests, if they've got abnormal kidney function, or if they've got a blood test pattern which tells me that they might have an infection, that will also move into and influence my overall decision. And then that all feeds into interpretation. And one other thing I think about with previous imaging as well is thinking about whether an abnormality on the scan is new or old. If it's something that's popped up in the last week, I'm going to interpret it very differently to something that has been stable over 15, 20 years. So that's really important as well. And this is a chest x-ray where a patient has a diagnosis. And there's not a very subtle abnormality on this. You can see that there is a big problem with one side of the hemithorax, and unimaginatively we call this whiteout because the whole side of the chest is whited out, and this is often associated with an underlying cancer. So, but I know this, but I still show this case to my registrars all the time because I need them to take into account what they see, but also the clinical implications and what it may mean for the patient. And so I even showed this today. So whiteout plus no good reason. So if I can't explain this straight off the bat, why the lung looks like this, for example, have they had a lung removed, or have they come in or breathed in a foreign body which has caused that lung to collapse? So a corn kernel or something like that. If there's no good reason for it to look like this, I go, this is whiteout. I don't know if there's a good reason, and therefore this is cancer until proven otherwise. And I don't expect, and this is something that I just know from reporting these over and over and over. And so I will say that I need the patient to go and have a CT scan. And other things that I look at with this is I can see that this bronchus is blocked. I'm concerned that there's a mass here which is causing this all to be obstructed and this lung to collapse down. So from my taking into account the clinical presentation, so why the patient is here and my experience and the imaging features, I go, this patient needs to have a CT because it's really important that we prove that we assess for an underlying cancer in this patient. So things I will do, I'll contact the referrer or the doctor who is looking after the patient to make sure I close that communication loop, and also recommend additional imaging, which in this patient would be a CT scan with some contrast. So two cases which both show opacities or white areas in the lungs. And so here we go on one, here's on the other, the second one being a little bit less subtle. But these are two kind of very similar conundrums. We've got density, we've got white areas on the lung. What is it? So how do we determine what our recommendation is? And a lot of this comes back to our patient's history and why they're here. So the first thing is the patient's age, and this is a child and this is an adult. Children are less likely to present with lung cancer. Older adults with a smoking history are much more likely to present with lung cancer. The child may have been had a fever, they might have been having infective symptoms and cough. The adult might have also both had some fevers or some cough, but this was a lung cancer. Could this be pneumonia? Maybe. It's a little bit more rounded than I would like, but that's one of the things that we look at. And if we cannot confidently make the decision, if on x-rays we can't always give the correct answer, we can say there is an area of opacity or a white area. It could be this, it could be this, it could be this, but here's what I recommend you do to help sort that out, and that's where we come in. So this is kind of my little kind of flowchart of how I think through that particular case we just saw. So consolidation, that's that white area we saw. I think about the patient age. I think about why they're here. What brought them to have this chest x-ray today? Is the finding new, or has it been there for a while? What are the imaging features? And then are there risk factors or red flags? So if that patient with this lung cancer here didn't come in with a fever, to me that's highly suspicious for cancer. And then what's my impression? So what do I think is going on? And then I will make a recommendation, and that might be another test, it might be progress imaging, it might be another imaging modality such as CT or MRI to help sort that out. But as we said, I don't always have the answer, and this is where good communication and sensible clinical judgment will come in to help us make those decisions. So coming back to, it was a bit of a fly through on how we learn as radiologists. And even talking to my registrars today, and I didn't have time to update the slide, but I said to them, I'm doing a presentation on how radiologists learn. And he said, well, during training and beyond, you have to report thousands of x-rays. You have to report hundreds and thousands of CTs and hundreds and thousands of MRIs. You just have to do it over and over and over and be willing to be open to that continuous feedback. And I wish I could stand here and say that it's all easy. It is so not easy, particularly when you are training with mentors who you desperately, as we're doctors, we really want to do things right, and we want to do things right for our patients. And it's a very humbling experience to be given continual feedback and continually spoken about how you can improve. So, you pull yourself together and you keep going and you keep learning and you keep growing so you can get better and hone those skills. So when you are out in the world practicing independently, you are the best possible radiologist you can be, and giving the safest and highest quality patient care for your patients. And it really is a lifelong journey. I still go to courses, I teach, I learn, and I really enjoy that part of my job. So just to round out, we report thousands of cases, we bring in our clinical knowledge, we think about search patterns, we bring in our radio diagnosis skills and lesion assessment, and we problem solve. But at the end of the day, really, the radiologists aren't doctors in dark rooms who are very solitary. We love engage. We try to engage with our patients and our colleagues, and it's to give advice on management, and also bring in those communication and professionalism skills. And that kind of brings me to the end, but I believe we've got a good 10-15 minutes for questions to round us out to 5 o'clock.
Amazing. Thank you so much, Sally. I knew you would be amazing, but I'm always just blown away by your energy and openness to continuously learn yourself, but also to help us understand what you know as well. So we do have some time for questions. You're welcome just to use the raise hand function, or if you're feeling a little shy, you can put your question in the chat box as well. Sally, while people are drumming up their bravery to ask you a question, maybe just give us a 60-second, instead of a 3-minute thesis, a 60-second thesis. What is your PhD on?
Oh, so the PhD, going variably because I get pulled in a lot of directions, but my PhD is kind of stemming from how we teach radiology to our Masters of Medicine and Masters of Surgery students. So the degree unit's been wholly online since 2016, and we're one of the only online master's degrees in the country which offers a radiology specific unit of study. So we're trying to upskill our non-radiologist clinician colleagues on how to better interact with medical imaging, how to improve their patient care through that as well. So we're looking at thinking about how we teach online, how we can teach better, what our students want. And from kind of what I'm seeing, really it's a lot of finding educational opportunities which are fit for purpose and pitching it right. So how you teach a radiologist or a consultant or a training radiologist is going to be really different to how you teach a surgeon or a medical student. And I'm really a big fan, and I've now since started working in the medical school, which I love. How I teach a first-year medical student is going to be a lot more basic than how I teach even a fourth year. So it's about building those skills progress-wise, and also making the specialty seem accessible. And keeping in mind early at the end of the day is I'm not teaching my surgical colleagues how to be radiologists when I teach radiology. I'm teaching them how to be surgeons who can work with radiology and medical images effectively to best treat their patients. And I think that kind of paradigm shift is kind of at the heart of why I'm doing the research. And hopefully next year, a little bit of qualitative interview-based research with my radiology colleagues about how we can better engage with universities and teach better to our colleagues.
Thank you. I love an education-focused PhD. Do we have any? Oh, here we go. There's a question here from Jill. Thank you, Jill. Jill's wondering how different ultrasound images are to report. Do you rely on the images, and how much are you relying on your sonographers?
Jill, that's such a fantastic question. And it's nice to see you, Jill. Nice to see you again. I'm very, very passionate about ultrasound. And one thing that was taught to me as a first-year radiology registrar at North Shore was that the circle of trust between radiologists and sonographers is paramount to our patient care. I have to trust that my sonographer that I'm working with is getting good quality imaging, and they have to trust that I'm going to interpret it in the spirit in which it was given. And I cannot, understate how important it is that I can trust my sonographers, and that they have a good quality of training as well. And I'm really proud to be part of the team on the Central Coast, because I know that we've got a really excellent ultrasound lead at both Gosford and Wyong who puts education at the forefront and really tries to make sure that our sonos are getting the best possible imaging. And a good case example that I had today is I was reviewing a case overnight for a 12-year-old with appendicitis, with concern for appendicitis. And I had a look at the images. My registrar overnight had said, "Oh no, this is definitely appendicitis." And I looked at it and I said, "Oh, look, I don't know." And because appendix was a little bit on the bigger side. She was a bit tender when they pushed, but it just didn't have the full hand to allow me to confidently make that diagnosis. And a 12-year-old going to theatre, that's a big thing. Like, it's a big operation. And because of what we say in our reports, we have the real potential to impact what happens to these people. So my approach to this was to call my colleague who was a scanning sonographer and say, what do you think? And that opening up that line of communication is really important. And that goes the same for CTs or X-rays. If there's something that doesn't make sense, I'm a big advocate for collaboration and asking questions. So she came in, I said, look, do you think this was appendicitis? And she said, you know what, it measured a bit big, but I wasn't sure. I kind of felt it was equivocal. And that's okay. We don't always have the answers. And so that led to a change in the report, and hopefully, you know, the child hadn't been taken to theatre. So that's good. And now we can throw it back to the surgeons who can take into account how she is today. Is she improving? They're not feeling hamstrung, but they need to operate. They're allowed to kind of bring in that clinical decision making or even progress imaging. So to me, like, it's super important, and being able to have that open line of communication to see what happened in real time. And ultrasound is a really unique modality in that you're actually physically touching the patient with the probe. But what happens in the moment and real time when you're scanning is so different to a captured moment in time, like a chest X-ray. So, you know, I like to use all of the information available to me to help the patients. Jill, what do you think? Are you happy with that? Lots of thumbs up.
I think Jill looks like she might be in a shared work area in Susan Wakehill, so she's probably not talking, but she's doing lots of hand gestures and typing and things like. There you go. Well done, Jill.
No, I'm a big fan of ultrasound, like what we can do. It's a great modality and a lot of art to it.
Thank you. Do we have any further questions for Sally? Oh, Marcus? Maybe, Marcus, if you could just tell Sally who you are, because I'm not sure you know each other.
No problem. Hi, Sally. I'm Marcus Kitchen from Monash University. I'm a physicist here in the school. Thanks for a great talk. I particularly loved your gorillas in the lungs. They were very cute. I was just wondering about things like gorillas versus lung nodules. There's obviously a lot of psychology involved in what you do. And if you go looking for lung nodules, for example, I'm sure you might find lung nodules, but how do you stop yourself from seeing things that your brain is looking for that isn't actually there?
That is such a great question. And I tell you what, when you're prepping radiology registrars for exams, the amount of things that they imagine that they see on X-rays because they're looking for pathology is just, it will astound you. You know, and then it's also that pre-test probability as well. Like if you're expecting to see something, you know, it can be, you can start to see things. And I think a lot of that comes with experience, and seeing lots of things and kind of understanding what's normal or what the range of normal can be, because different patient, like everybody's different, everybody's anatomy is a little bit different. And, you know, some things, and knowing when something is something or something can be left alone is just something, if I'm saying something a lot, is just develops over time. A great kind of, one of the great educators in Australia, Frank Galab from Radiopedia, did a fantastic talk I saw a couple of years ago, which really resonated with me on this. And it was that if you're trying too hard to jam an imaging finding into a diagnostic box, like trying to put a square peg into a round hole, you need to stop and think, does this actually belong? And there is often a tendency, particularly if there's a concern for X diagnosis, to make the imaging fit it. And I think it's just that self-awareness which comes with experience, that if you're trying too hard to make it fit, that maybe you need to consider something different. Yeah, hopefully that kind of answers the question. And also we have a lot of guidelines which help us with this. Like for lung nodules, for example, we use something called the Fleischner guidelines, which helps us with size and morphology, or what the nodules look like, to help us base our recommendations, like when we should worry and when we should do progress imaging, and when we can confidently say, don't worry about it and leave it alone. And that has a lot of evidence behind it, which makes me feel more confident. We do the same with thyroid nodules as well. Hopefully that, sorry, I went off in a bit of a tangent. Does that answer the question, Mark?
It does, thank you.
Great, thanks. Yeah, there's a lot of collaborative knowledge, I think. A lot of law.
And I think, Marcus, that's not too unreflective, if that's a word, for a lot of radiographer reporting that might happen internationally, is that we're pretty good at finding pathology, but sometimes not so good at keeping those specificity scores up. And I guess sort of the tendency to overcall things for fear of missing them. And I should actually say that I was in Louisville when that study with the gorillas was undertaken by the Harvard group. And then I think the next year they were not invited back to help do experiments with the radiologists because there was, concern that there was perhaps an intention to deceive about the true nature of the study, although there wasn't, and they are fantastic colleagues and they're very, very clever, but you could see how it can be, the way that it was reported was quite unsettling, I think, to many of the radiologists, and didn't think it was perhaps a fair test, but it wasn't, there wasn't that intention, but I can see how that may have come about. So
I haven't ever found a gorilla in the lungs before, but I guess that's not to say it wasn't there, but not yet.
Just weren't trying hard enough, Sally, like could be there.
That's it. But yeah, like, I think that's it as well. And I will throw in there that one of the hardest things to report on the bottom of a scan is normal. I find whenever I'm calling something normal, this pit of my stomach drops out going, oh my goodness, have I missed something? So I find, there's always often that tendency to try and find something, which, we have to make sure that we're not overcalling and complicating things for patients, because for every incidental finding or incidental OMA that you find, you're potentially committing the patient to further tests, which is further radiation, further further inconvenience, or even at the worst case, biopsies or invasive tissues to characterize something that may or may not be nothing. So the onus on being able to call things normal and the confidence to be able to do that is really important in a lot of cases.
Yeah, thank you. Okay, I'm just looking at the time, and I think we'll probably wrap up today's session. We picked your brains thoroughly apart, Sally. Thank you so much. A really big thank you for presenting today to our group, and I know that many people will also view your talk online. I think next month we have Professor Stephen Hilliers from the University of Iowa. He's a professor of radiology and perception. So we were ending on that note of perception. And he also is a absolute master of statistics and the way that we do statistical modelling around multi-images, multi-observers. So I do encourage you to come along next month if you can, and or catch up with the recording. But on that note, thank you again, Sally, and good afternoon, everyone.
Thanks, everybody.
Thank you.